My name's Rachel McCarthy. I'm the Business Analyst and Deployment Lead in BI for Northwest London ICB. And today I'm going to be giving an overview of the Whole Systems Integrated Care, otherwise known as WSIC, to provide everybody who joined today and anybody who's listening to the recording overview of what is WSIC and how can we utilise WSIC. Just as a reminder before I get started, if anybody's joined and not on mute, if you could go on mute, that'd be brilliant. Thank you. Okay, so first of all, talking about analytics to improve outcomes across the country, the ICSs have 4 main objectives, and these are to improve the outcomes of population and health care, prevent the ill health and tackle the inequalities and outcomes of experiences and access for our patients, enhance the productivity and value for money, and also to support the broader economic and social development. For these 4 objectives, it is quite clear that they will need a data and digital as a foundation to them. And in Northwest London, we have WSIC, which over the past 10 years we've been developing, and it's been used across the system for a number of different use cases, and it will be able to support these 4 objectives as well. So to give a little bit of a view on what is our vision for WSIC, we utilize the information to think about our patient in the center. So we have this linked data set of integrated information to help improve population health for our patients. And where we think about the patient being central to this and having their holistic information, it's there to be able to drive direct care, population health, and also research. And from that, we have to think about what are our key purposes for WSIC, for this longitudinal data set and a dynamic dashboard in order to view this data. So a couple of the different sort of key outcomes that we look for are to identify the patient cohorts for case management and case finding. So this is utilising identifiable data and seeing that being used for those purposes. Also, to be able to integrate lists back into clinical systems, to be able to identify different health inequalities and appropriate interventions within those areas, enable multidisciplinary team meetings. This is to help discuss the patients and agree interventions across the system from a system-wide approach. Enable better patient experience as healthcare professionals are going to be working closely together. Better health outcomes for the population as interventions are applied to reduce the emergency activity and turn to more proactive care. And of course, staff working more closely together to deliver this joined up care approach. So what do we think about our population within WSIC? So our population is the registered patients in Northwest London. So that's approximately 2.88 million patients in Northwest London that we have data for in WSIC, which equates to about just over 98% of the Northwest London population. Now, to be transparent, one of the reasons that we don't have 100% in there is because there are 3 practices in Northwest London who don't share their data into WSIC, but the rest do. So that's really quite a brief overview of everything that we're talking about with regards to WSIC to sort of frame what we're going to look at. But I'm going to move on into a little bit more detail about what does this WSIC actually mean and what do we do with it. So WSIC, to start off with, it is just a big joined up data set. So that means that we have linked data coming in from multiple different care providers. So if you think we got data coming from local authorities for social care data, community data coming in, primary care GPs, clinical systems data, hospitals, acute mental health, etc. And that's all being brought into WSIC and then being linked up in that. In order for us to be able to do that, we have to have a really robust information governance model behind this, which we do. And this has grown to support those purposes that we looked at the beginning slide to think about what are our purposes for the data. So we have this linked data set. Now, the way that we link this data is through using the NHS number. That means that all of our data that we're getting in is patient identifiable. And then we use that NHS number to link the patient record across the data that's coming in from all of these different care settings. So on one side of the diagram here, we've got identifiable information. And the identifiable patient information is accessible by clinicians. And through that, it means that we have to have a tight roles-based access in place to ensure that the people who get access to this patient identifiable information have a legitimate relationship with those patients. And by that, I mean, if you work in a practice, you see the patient's identifiable information to those patients registered in that practice. And in that identifiable area, we look at this data and present it in three sort of different ways. So we can do this by integrated patient summaries or individual patient pages showing a holistic view of the activity over time of their key indicators right now, and just look at that one patient and see like a whole story about that patient from the data that's coming from multiple different care settings. We have case finding tools, so ways to identify who are our patients who are meeting certain criteria. And we've got things like watch lists, which include patients who've been newly diagnosed with an LTC, patients who have care plans out of date, attend A&E multiple times, have multiple inpatient attendances, or recently DNAing on a number of occasions. So this can be ways of case finding cohorts of patients. We also have the long-term condition management tools. So we'll see this a little bit later on in a bit more detail. But the long-term condition management tools is a way that utilising that wide data that we have in WSIC, we can start to identify who has a long-term condition, and then put against that the number of specific metrics or indicators that relate to that long-term condition, and look at a list of patients who meet that and see how are they doing against each of those indicators. So that might be something like asthma. So everybody who's got an asthma long-term condition, and then saying, okay, what are the metrics against that? Might be something like their prescription. So an ICS prescription, how many have been had in the last 12 months? Maybe it's the asthma plan being in place. When was it last updated or reviewed? Even things like peak flow. When was the last time a peak flow test was done, and what was the latest result out of that? So these sorts of identifiable dashboards are available to provide a whole range of information relevant to their use cases. On the other side of this, so all that identifiable data is then de-identified for secondary care purposes, so such as operational analytics or commissioning analytics, benchmarking, population health management, and public health analytics. And this can be viewed in two ways. So similar to the patient identifiable, where we can create dashboards, and we can use something like Tableau to create those dashboards to present the data back at a population level. And we can also look at that to look at some benchmarking as well. But additional to the dashboards, we also have this de-identified data set, which is there for the analysts and the researchers to be able to utilize that data in the back end and create the queries that they require to answer their specific questions. So of all of this data that we have linked, we are able to also build and run a number of algorithms on top of this, such as long-term conditions. So we mentioned that it's clearly used in the patient identifiable side, but it's going to be used across all different use cases. We also have the electronic frailty index. It's created on top of the WSIC data. Q admission, patient segments, risk stratification segments. And this is all in order to be able to group, cohort and segment those patients into different categories. So how and what do we bring in is the question. And these next few slides are going to explain the vastness of the different types of data that come into WSIC that's available to utilize across these dashboards and in the de-identified area. So we have a number of different care settings, and start off with our primary care, our GPs. Now, what we'll see as we go through this, that not every data source that we get in is going to be at the same frequency, same granularity, and I'll explain that as we go along. So our GP data that we get in, this is all coded data. So in the practices, they have systems called EMIS and System 1, and they use something called SNOMED coding. So everything that's got a SNOMED code is then flowing back into WSIC. We get this data daily, and it's got a data lag of 1 to 2 days, mostly a day lag, but sometimes a 2-day lag. And that means that anything that was recorded yesterday, we'll see in the system today. And that's how that one works. So it's one of our most granular and frequent data sets available to us. We have acute data from our 4 main providers in Northwest London. And as you can see here, there's quite a number of different data sets that we get in, and each one of these provides a different level and richness of data coming in, but all complement each other. I'm going to explain. So we've got the service level agreement monitoring, otherwise known as SLAM, and we'll see this across a number of our different care settings. So SLAM data is our nationally agreed specification that's used for contract monitoring, and it comes in monthly. This data is monthly in arrears. So it means that at the end of this month, we get the data from 2 months ago going backwards. So it's always monthly, but it's a month in arrears. Then we've got the secondary user service data set, which is known as SUS. And that's the national activity data that we get in. Again, it's monthly and in arrears. To complement this, we have A&E inpatient and outpatient data, which is coming in weekly. So this provides a more frequent data set that complements that SUS data that we've got in on the monthly basis. We also have waiting list data, children's virtual ward data, and post-COVID assessment data, which comes fortnightly. We've got patient level costing systems data for Imperial and Chel West, which if anybody works in that area have heard of it, it's been called PLIX. And we also have pathology data, and there's quite a lot of pathology data out there, and it's something that we take different sets of that pathology data on bit by bit. So we have quite a number of pathology information in there, but there's always, room for improvement to bring in more data as and when the use case is available and tells us that that's something that we need to bring in. So we'll talk about how do we ascertain, how do we know what we need and what we don't need, and how we use that in later slides. Now, for quite a number of our patients, of course, they may well require to go to hospital outside of Northwest London for many different reasons. We also receive that information on a monthly basis through the SLAM and the SUS data sets. So for our out of area providers, we get that data in as well. So more care settings, more data, more granularity, more richness to this data warehouse. Community data. So from our providers that are providing community services, we receive the SLAM data monthly. We also receive the data that comes from in our community providers, if they've got a System 1 or EMIS unit, that data is like the GP data that comes to us on a daily basis with a 1 to 2 day lag. We also have post-COVID data and looked after children and SEND data that comes in monthly. Mental health, we've got data from our mental health providers. So we've got the SLAM data again, same as community. If they've got a System 1 or EMIS unit in their organisation, that data comes through to us in the same way that the GP data comes into us on a daily basis with a 1 to 2 day lag. We've also got liaison psychiatry data weekly and CYP mental health data from CNWL, which is coming from the mental health service dataset. And then finally, out of these care provider care settings, we have social care data. So from our local authorities, all 8 local authorities provide us with adult social care data that comes in monthly. We also have some children's social care data. As we mentioned, we've got the child in need and looked after children's data on a monthly basis. But we also receive for Kensington, Chelsea, Westminster and Harrow, the SIN census and the wonderfully named data set called the SSDA 903, which is looked after children's and child protection plan information. This is an annual data set. It's very granular. It provides quite a lot of information in those areas. And we are currently working with our other 5 local authorities to extend that to the whole of North West London. So that's one of the pieces of work that we are doing at the moment. Now, we don't just get data from our care providers, but we also have additional data sets that we bring in to supplement the health and care data. So we have data that includes, understanding our deprivation deciles across North West London. So knowing where a patient lives and which deprivation decile is within that area, that can provide some key information around deprivation and inequalities in that sort of section. We also have pollution data that comes in annually. We have consent to contact, which is a research register. Consented patient survey data, which comes in daily. This is around rheumatoid arthritis, which is a pilot called Remora that's happening in North West London. So that data very much provides information specifically for that pilot. We also have lung health data and EPC, so the Energy Performance Certificate to do with properties. That's a monthly data set, also monthly in arrears. And then finally, we've also got the frequent callers that comes from the London Ambulance Service. So we know in North West London of our North West London registered patients, those who are frequent callers to the LAS service. I am aware there are questions in the chat. I will try to come to them at the end. Just so you think I'm ignoring you, I'm not. It's just I'll try to answer those ones for you towards the end of the session today. So WSIC is set up as a trusted data environment, and here want to explain the life cycle of the need for the dashboards and the data to actually getting that data and feeding it through. So if we take a look at the collect and store, so 1 and 2, this here is describing how we acquire the data and then ingest it into WSIC. So it becomes an available data in WSIC to be used. Once that data is available, we have the curate and catalogue section. And this means that we're thinking about linking it all, doing the transformation, cataloguing it so we can understand what we have and how to use it. Following on from there, this is then item 4, which is inquire and explore. This is where the analysis is taking place. So from an analytics point of view, how are we going to query that data and get out the information that we're looking for to be able to answer our questions? 5, how do we present it? So we can use Tableau to present a dashboard, to create a dashboard and present that information back so that the information can be self-served. So users of the dashboards are able to go in and get that data out on a regular basis. And 6 is the act and interact. Once you've got the data, what do you do with it? So 1 through to 5 is all covered within BI. And what we ask of everybody here is 6. What are you going to do with the data? And as I said, this is a cycle. So really at the beginning of a lot of our processes, we think about the question, what business questions am I trying to answer? What do I want the data to show me? And what am I going to do with that information once I've got it? And then that produces those use cases, those plans or SOPs or processes on how to then utilize data effectively. And it's an ongoing cycle. We don't just create a dashboard or a report and that's it, done for life. You know, there's always changes, there's new information required, there's changes to the data, maybe new codings being used. So there's always changes that will keep this cycle moving forwards. Now, I mentioned earlier about some transformations and some algorithms that we put on top of the data, and I'm going to explain a couple of them to you so you can see what's actually available in WSIC. It's not just about having this rich data source available where dashboards are created off this and they look all pretty and we can do some things with them, but actually create some bits and pieces in WSIC ready to use so that individuals don't have to go away and trying to figure this out for themselves and being able to click here, click there and make lots of things happen before you get to your answer. One of those algorithms that we create on top of the WSIC data is the population segment. And so here, I'm going to try to explain how this actually comes to be. We have data that comes in from TPP and EMIS. TPP is system 1 and EMIS has EMIS is EMIS. And that all flows into our Compass data warehouse. So then it all meets the specification and the data looks the same and it can be utilized in the same way. And we've got then also data from acute community and mental health services that also flow. And all of this all flows into our WSIC Snowflake environment. So once all that data is there and it's all linked together, we want to do our patient segment. So what do we need to do for our patient segment? So in our team, the patient segment is created on top of the data. And the first thing that we need to do is work out all the long-term conditions and apply the logic for each different long-term condition to the patient's data. And that gives us a register for each patient and any long-term conditions they have. We also ensure that we're looking at the registered population for North West London, because the data also includes deceased population and patients who have previously been part of the North West London footprint, but have now left or moved out of the area, gone to another GP practice. So once we've got all that, and alongside all of the rest of our linked data, we can start to think about our different segments for our population. And the first thing that we do is we think about our age for our population. So we look at all the people registered in North West London, and are they under the age of 18? If they are, we're looking at the green line here, the child line, and then we ask ourselves the question, are they part of the complex health needs cohort? So what is the complex health need for children? So it's things like patients who are under the age of 18, they've got multiple long-term conditions and things like 5 or more pediatrician outpatient appointments, multiple specialties through outpatients. They could have a mental health inpatient stay or 7 or more community diagnoses as well. So all of this information coming from the data will let us know whether those patients meet that criteria. And if they do, their segment will be the complex health needs, the child complex health needs. And then following that green line down, the next thing we do is saying anybody who's not in the child complex health needs? Will they be in the child one or more long-term condition? If they're not part of the child one or more long-term condition, they're in the healthy cohort. Then we say, right, now we're looking for our adults. So this is anybody from the age of 18 and above and under the age of 65. We follow the blue line down, and the first thing we want to understand is, do they have a learning disability? If not, do they have dementia, Alzheimer's, or a cognitive decline? If not, do they have a severe enduring mental illness or SMI? If not, do they have one or more long-term condition? And then finally, if none of those apply, they're in the healthy category at the end. The same applies for our older people's population, which is the 65 and over population. And we'll see here along the grey line here, it's the same categories as we've got for the adults, leading us then to the healthy category at the end. So we have also risk segments. So there's different ways of segmenting population, not just the way I've shown, but we also have risk segments as well in WSIC. So these are just two different types of algorithms that we apply on the WSIC data. And in the WSIC risk segments, there are a split again between adults and children. And here I'm showing just the adults risk segment for today, for the purposes of today. So not to go through every single detail in today's session, but to explain that the risk segments actually look similar in the sense that we have 5 risk segments, whether it's adults or children. The difference comes to the detail of how do we understand the algorithms behind these. So we have the specialist end of life, then high risk, rising risk, stable risk, and the well population. Same sort of approach applies. First thing we do is we look at our population and we see if they meet the criteria for the specialist end of life. If not, then do they meet criteria for high risk, rising risk, stable risk? If not, the population is, the patient will be in the well category at the end. Now we can see that on average, our population, so we've got 77% of our population, which will be within the well category, 19% of our adult population in the stable risk category, 0.6 for the rising risk, 2.9 for the high risk, and 0.7 for the specialist end of life. And that's how the population looks across these segments. Now, as an explanation, just one of the use cases for these risk segments comes specifically around the rising risk segment. So the use case in this for this one is if there are patients within the rising risk segment. This is a cohort of people that clinically we think we can do some really good interventions with in order to reduce the likelihood of them becoming a high risk patient and actually probably be able to move them into a stable risk category. And in stable risk, what we mean there is that somebody will have like a long-term condition, but is maintaining and managing that through their own self-care without requiring a lot of healthcare interventions. So that's one of the use cases for these risk segments. Now, how do we view this is what we're going to look at next. So we have dashboards developed on WSIC and they look a little bit like this. And what I'd like to do is actually show you one working for real. So I'm going to bring over the asthma radar. Here we are. So this is our demo environment. And this is what one of those dashboards actually looks like and how it will work. So we have a design principle for all of our dashboards, first of all. So the reason we have this design principle is that we have quite a number of dashboards, many use cases, and we want to ensure that is easy to move from one dashboard to the next. It's not going to look severely different or difficult to use. So once understanding how the dashboards work, how to navigate through them, it makes it a lot easier from a user's perspective to move from one dashboard to the next if you're using multiple dashboards. Yeah, so this is our asthma radar. As I said, it's a demo account, so all the information that you'll see on there isn't real. And the first thing that we see on the dashboard is a purple banner. Now, this part of our design principle, it ensures that in every dashboard we have some key information that's consistent. And this gives information about how up to date the data is in the dashboard. When was the dashboard last refreshed? So is it a daily refresh? The information on the dashboard's updated daily? Or is it one of these that we have agreed to update on a weekly basis or monthly or quarterly basis? We also have this I button, which gives further information and also links to some of our supporting materials. And I'm going to show you those again a little bit later on. And then we come on to all these different filters. So filters tend to, on the first line, tend to be fairly similar across every dashboard so that we have that consistent feel. We can split the list down by borough, PCM practice, and then also things like age band, deprivation, ethnicity. And we just talked about the patient segment, and that's how we can see that in here too. Now, people who have access to patient identifiable data, they'll only see the patients they have a legitimate relationship to. So the lists are really narrowed down to only those patients. But then there may be a requirement to understand those who are in our lowest decile for deprivation. We can choose those filters, apply that, and it changes who we see on our list. We might only be interested in our children in this case. So again, get to choose that, see that, and the list changes again. What you'll see on a lot of the radars, this is what we call a radar. It's a way of RAG rating a number of different indicators specifically used against the purpose for the dashboard. In this case, it's identifying the asthma population and then highlighting sort of red, amber, greens across different care indicators, which will really help to identify areas of need and intervention from a clinical point of view. And each one of these, you know, has a hover over tooltip, and it provides a little bit more information that we can see. So those that have had an asthma plan put in place, when it was last completed, and where it's been completed at. So that's a population health, a patient identifiable dashboard. And now I'm going to talk about the population health dashboards. So population health is the dashboards that are available to those that have patient identifiable access, but also available to those that do not have that patient identifiable access. So we can look at the same sort of data, but at a population level without identifying the patients. Now, we have, again, a design principle here where we look at our data through 4 different quadrants. And those 4 quadrants are the population, clinical, finance, and the lifestyle change or wider determinants. And again, I'm going to show you a dashboard here that looks at that. So we have, at this level, it's only looking at a whole Northwest London wide level. And there's no drill downs or anything. It's all at this top level, but we can drill down into each area into much more detail. And this is the example of the hypertension dashboard. Again, in our demo environment, you see like everything's a bit made up. We've got these same filters again at the top, but then we've also got some specific filters that are just really relevant to this particular request for this dashboard. Now, what I want to explain is, how do we actually get here? You know, WSIC team, we're not deciding what goes into these dashboards. We're not the ones saying how it's all got to look and and how it's going to be used. So the way we get to this point is we first have to have our discussions with the clinical and operational leads requiring the dashboard. And part of that is understanding, what do you want to ask of the data? What are your questions, or what answers are you trying to get from the information? If we create a dashboard, what do you want to be able to see from it? And then also, how are you going to use this? And all of this requirements gathering is really helpful in order to create a dashboard that is fit for purpose. It means it is going to answer the questions that you're looking to answer. It can be used in the way that you're expecting it to be used. And it is fit for purpose, and it brings value to the organisation and to our patients. Once we've done that, that will allow us to mock up some dashboards. So we don't just go away and think, oh, what we've heard we'll understand and we'll make a perfect dashboard. Of course not. You know, sometimes we look at the questions and the requirements that are needed, and we'll mock it up, say, look, this is how we think we should present this data back in a dashboard. And this will be a conversation where, between the leads and ourselves, we'll understand more about how it's going to be used, whether those types of graphs or the way the dashboard navigates, what we decide to put, which data elements on each different dashboard, how that's all going to be used. And then we might go through a few iterations of that before agreeing on the actual look and feel of the dashboard. But once we've got that, it goes through to development. It's tested, again, clinically and operationally, it will be tested. And then it is put into production, and that's when it becomes live for everybody to use. So not only do we create dashboards, but we also create a number of supporting materials to support with the use of these dashboards. And this can include, so we'll have a website, web pages on the ICS website, and we've got a number of different areas in there covering a lot of what I've talked about today, both on the patient identifiable side and the de-identified, the population health, lots of information in there. We create user guides, and this explains how to navigate through every single dashboard that we've created. It also includes information on the logic that we're using for every metric. And we provide the code sets as well behind each of these metrics and logics that we are applying. And this is really to help be transparent in the number that you see on the dashboard. How have we got there? You know, it's being as transparent as we possibly can be to show you how that number has been ascertained. We create quick reference guides. So these are like 1 to 2 page documents specifically created for use cases to explain, how to navigate through a dashboard, find our 17 to 50-year-olds and those who have in the complex, adults with one or more long-term condition, for example. So we'll explain very specifically how to do that. It might be more along the lines of those who have blood pressure reading that is outside of its range for the target, and so on. So there's lots of QRGs created too. And then we also create the videos to help support the use of these dashboards. So we have a YouTube channel. It's called the North West London Whole Systems Integrated Care WSIC YouTube channel. And all of our videos will be published there as well. Now, I'm going to show you the website here. So let's just scroll up to a little bit at the top here. So this is our dashboard, user guides, videos and support material on the ICS website. And we've got all those user guides in there. You see quite a few. We've also got all these demonstration videos. And if we take any one of these, when you click on the link, what it will do is it will take you to that YouTube channel. And of course, in YouTube, you might get an advert first, but then it will automatically take you into the video for that particular dashboard. Right. Now, that was a lot of materials for our users of the dashboards, but we also have patient communication materials as well. Over the past 10 years, we have continually done patient engagement. We've done face-to-face sessions, we've organised Northwest London-wide communications, and we create materials that are also available on our website for the patients themselves. We are trying to be as transparent to our patients as possible to ensure they understand how their data is being used and how it comes together and what the purposes for this data are, and through that. So we've got a number of different materials available on the website for this. This is, again, as everything else, this is something that we don't stop with. There's always continual engagement that's happening. Now, governance arrangements. So there are two different pathways to accessing WSIC, whether we're talking about the dashboards or the de-identified data. So two completely different processes that are in place. Dashboards, access to the dashboards, to the patient identifiable and the population health dashboards all work through the WSIC support team. We have user access forms available, and because of the number of different ways, different levels of access available, we support the users through the process depending on the type of access that's required. So whether it's patient identifiable data for the care professionals or the population health data for those who don't have a direct care relationship, so for example ICB staff. And then the second pathway is access to the de-identified data. And this is mostly how do our analysts and researchers get access to the de-identified data to build their own queries and reports from the data. And this is a different process in the fact that it goes through the Northwest London Data Access Committee, which has a number of IG regulatory questions in order for it to be approved. And with that data access request, there's a specific form that has to be completed in. There's an acceptable use policy, and users would only be granted a maximum of 6 months access to that data. And as they're coming up to the end of that 6 months, they will have to go and ask for an extension to the de-identified data to carry on their analysis where required. But for the dashboards, as I mentioned, different type of process in place. We've got a different type of form. It works directly through, the WSIC support team who will advise and help get access. And we also, I really want to mention this because this is one of our great achievements in the last couple of years, is moving to single sign-on. And the reason I say this is a great achievement is because it was a massive barrier, for all users to dashboards, having to remember another username and password and enter it every time they want to get to a dashboard, or they shut down, start the next day, have to go through the process again. And it was quite cumbersome, alongside the fact that at that point in time, everybody had to remember a number of different username and passwords. So it did add on to the number of issues raised and password reset requests coming in. So having a single sign-on approach meant that this really removed one of those massive barriers to actually being able to get access and use the dashboards. So now when somebody is set up with access to one of the dashboard, to either the PID or the population health, they log in for the first time, and after that it's partly remembered. So it's like, when we log in and into our computers, and then Teams just works. After the first time of logging in, we don't have to do it again. So it's that same sort of approach. That means that it makes it a lot easier for users, but still securely able to access the dashboard. So I know this question comes up quite a lot, so I do want to cover it, and it's how to raise a request for a new dashboard or even enhancements and changes to existing dashboards. So in the WSIC support team, we have a dashboard request form that it needs to be completed. It is also available on the website. So the website has so much information. It's great. It will give you loads of really helpful information there. The form needs to be completed and sent across to WSIC support. We also provide an example filled out form, so it gives you a really good idea of what the questions are looking, what answers we're looking for in those questions. Now, the first thing that happens is our business intelligence team, our senior management team in BI will triage that request to ensure, one, we've got the information required to really understand what the request is, to understand, is it possible? Do we have the right information, the right data? So going back to that life cycle I showed earlier, we've got to think about, you know, what data do we want to bring in? Is that the right data? Does it have a use case? And when we're thinking about that, if we have a request and it has a use case and the data's not there, there is a process to follow to bring in new data. But we can see that and we can triage that through this triage. We can also understand where the requests come from, which programs are there, is it most appropriately linked to. It might have come directly from a program or a CRG, but also if it's come from an individual, we can also advise back about which program it links best with. And the reason for doing that is to go through this approval process and prioritization process. There are a number of requests that come in, and we do really want to ensure that what we are working on is the priority for the organisation that's going to bring benefit to our patients and value to all of our services. So we do take these requests and go through the appropriate programs to ensure their approval and prioritisation. For every request, we always, for WSIC, we always work with clinical leads. And this takes us through that development cycle with regards to what do we need to achieve, how is it going to be used, let's get it tested, make sure it's working right. Does the numbers, you know, sense check the numbers, does it all, you know, add up? And then we get out to production. Again, working with the clinical leads and operational leads, really to identify those use cases and get them written down. Make sure that those are well documented and understood. How is it actually going to be used? Who is it going to be used by? What's the intended purpose? And again, what do we expect to happen once that data is ascertained? You know, what happens next? We do look for our CRGs in Northwest London, particularly to take ownership of dashboards or programs. So again, this complete feedback loop of what dashboards are out there. Are they still relevant? If they are they completely up to date? Do we need feedback on new metrics, new codes that might be being used? Is there a change in process? And this really ensures that every dashboard that's there can be kept up to date and fit for purpose. So, thinking about everything that we've just looked at in regards to WSIC, what are our benefits of actually having this joined up data? So in Reflect, we can identify and support patients for targeted care by having joined up data. It helps facilitate the discussions and coordinations between different care professionals and aids the MDTs. It also supports discussions with patients. It provides that holistic view rather than having what do I know just from this one care setting. It gives more of a picture of everything from that health and care point of view that's happening with that patient, and will really help support a richer conversation with the patient. It can reduce duplication. So imagine you've got test results, blood tests happening at primary care and also in the mental health service. And by being able to see when the latest blood tests and what blood tests have happened and the outcomes of those blood tests can help inform from a clinical perspective whether further blood tests need to be taken or not. Understanding the impact of the health and social care. So this isn't just healthcare data, which I think, you know, we've talked about. Bringing in that social care data really, again, provides that richness around the whole holistic view of this patient's care. And understanding the needs of the population. So really looking at that population data and seeing from that level, that view, where we may have some really good ways of working and also other areas where we want to improve. And then finally, we've got the strategic planning benefit, utilising the data to help with that planning and analysis. So, thank you very much, everybody. It's been lovely to come and speak to you all today. If you do have any other questions or something that we haven't quite managed to answer, so really thank you to the team as well, because I've seen that they've been trying to answer the questions today as I've been talking. So thank you very much to my team and Kavitha as well for joining. Yeah, please do email us and let us know if you've got any other questions. Maybe I haven't covered something or explained it quite right. We're more than happy to answer that. Also, I'd like to inform you that we're going to do some future sessions in September where we're going to drill down more into the detail on dashboards and how they can be used effectively. So today's really been that overview, that sort of baseline on what is WSIC and its use cases, but we will be doing some future sessions in September. So look out for that. It will be advertised and I'd love to see you there. So thank you very much.